I welcome people to the today's meeting of the Health Occupations and Long-Term Care Subcommittee of the Health and Government Operations Committee. We have 4 bills before us. We're going to go in numerical order, except that House Bill 806 will be heard last.
Yeah.
That would be 499, 959, 1053, 806. Council, could you please describe House Bill 499, Health Occupations, Private Dental Offices, Infection Control Delicate Bagnals Bill?
This bill was also discussed at the last meeting. The bill requires each owner of a private dental office to designate a licensed dentist to be the supervising dentist for the office. Supervising dentist must complete the registration required by the State Board of Dental Examiners and be responsible for all infection control activities within the office as specified. As originally introduced, the bill required specified that a supervising dentist may supervise up to 3 private dental offices within close enough proximity to allow for personal oversight of each office. If a supervising dentist relinquishes their responsibility for infection control activities, the owner of the private dental office must immediately designate an interim supervising dentist until a new supervising dentist registers with the board. I circulated amendments from the sponsor that define infection control activities, removes language that would have limited the number of private dental offices a supervising dentist may supervise, and clarifies that the requirements of the section do not fall under the definition of practiced dentistry or limit the ability of an unlicensed person to assist with regulatory compliance requirements.
Is there discussion? Are there amendments? Delegate Bagnall, you have your amendments. Do you wish to offer them?
Thank you. Thank you, Mr. Chair. Yes, these are consensus amendments that were worked out with the stakeholders and the Board of Examiners, and I would move the amendments.
So moved. Is there a second?
Second.
All those in favor of the amendment say aye. All right, that's the lit. That's fine. Are there any other amendments, or is this consensus amendment take care of any amendments that were being considered? Delegate Bagnall.
Now, these are all the consensus amendments. I know that we had an outstanding question from the last meeting, and these are all encompassing.
Great. Is there a motion on the bill as amended?
Move the bill as amended.
Second.
All those in favor of the bill as amended, please say aye. Aye. Is there anyone opposed to House Bill 499 as amended? So moved. We'll now go to House Bill 959, Health Occupations, Certified Dialysis Technicians, Continuing Education Requirement. Delegate Bhandari.
This bill alters the continuing education requirement for certified dialysis technicians renewing their certification. The bill requires 3 hours of continuing education approved by the Maryland Board of Nursing rather than a 3-hour continuing education course approved by the board. I didn't bother to circulate a piece of paper saying this, but at the bill hearing, Dana Kaufman, one of the advocates on the bill, requested an amendment to alter the effective date of the bill from July 1st to June 1st. I hope everyone agrees. I felt we could vote on that in concept rather than having a piece of paper that said it.
Is that the only amendment?
Yeah.
Okay. So we'll consider the amendment to be offered and seconded.
Move the amendment.
So moved. All those in favor say aye.
Aye.
Unanimous. Amendment, motion on the bill as amended.
Move the bill as amended.
Second.
Moved and seconded. Is there any discussion? All those seeing no discussion, all those in favor of the bill as amended, say aye. Raise your hand, whatever. Anyone opposed? No. It is unanimous. House Bill 1053.
As introduced, this bill would have required the Maryland Department of Health to convene a stakeholder work group to study the qualifications for the executive director of the State Board of Nursing. I circulated amendment from the sponsor that rather than requiring the study, the bill repeals the requirement that the executive director of the State Board of Nursing be a registered nurse and specifies that the bill takes effect July 1st, 2025, or on the termination of a portion of last year's bill transferring operational control of the Board of Nursing to MDH for 2 years. So if that date were to change, the effective date of this bill would change. But for all intents and purposes, July 1st to 2025.
Okay. Are there any amendments to this bill?
Those were the amendments that I just described.
Okay. Is
From
there a
this list.
motion on those amendments? So moved and seconded. Any objection to the amendments? Okay, is there a motion on the bill as amended?
Move the bill.
So
as
moved.
amended.
All those in favor of the bill as amended? Oh, Delegate Morgan, sorry.
Hey, thank you, Mr. Chairman. Is the Maryland Nursing Association on board with this? Now, I saw they had some opposition testimony.
Don't imagine so. They didn't want it even studied. So changing the requirement, probably not. I see Robin shaking her head.
Robin, you are recognized. Robin Elliott.
Good morning. So the Maryland Nurses Association is not on board, but we understand that the committee may go in a different direction, and if so, we look forward to working with you on many other things. So thank you.
Understood. Okay, Delegate Morgan, I'm sorry. We can't hear
I'm
you.
done. That clarified it. Thank you.
Yes, okay. All right, so their bill is before us. All those in favor of the bill as amended, say aye. Is anyone opposed to the bill as amended? Okay, it is unanimous. House Bill 806, Physician Assistance Revisions.
That was easy, Marie.
Physician Assistance Modernization Act of 2024. Council?
This bill requires a physician assistant to have a collaboration agreement rather than a delegation agreement and authorizes a physician assistant who has submitted a collaboration agreement to the State Board of Physicians to practice medical acts that are authorized under a license issued by the board and the PA's collaboration agreement. The PA may perform additional duties within a PA's scope of practice as specified and personally prepare and dispense prescription drugs as specified. The bill also alters the education and examination requirements for licensure and makes other conforming changes. I circulated a couple of draft reprints of the bill. The stakeholders have been working on amendments. I'm going to provide a very broad overview of the consensus amendments, and then they can speak to sort of where they're still discussing points. The amendments, rather than requiring submission of a collaboration agreement to the board, provide for of the executed agreement and the information about the practice team physicians that are listed in the agreement. Limits when a physician assistant can delegate medical acts to licensed or unlicensed personnel based on the experience of the physician assistant. Clarifies what medical acts a PA may perform. And this language is also mirrored in the disciplinary language as far as the board disciplining a physician assistant. Removes language requiring 18 months of mentoring for new PAs. Specifies circumstances when a PA requires board approval to perform advanced duties, including the practice settings in which a PA may perform advanced duties without board approval. Establishes the board's authority to modify a collaboration agreement or the delegation of advanced duty under the agreement, and establishes requirements for a patient care team physician to delegate prescribing and dispensing of controlled dangerous substances, prescription drugs, or medical devices to a PA under a collaboration agreement.
Now, I'm going to ask the interested parties a question. I know you've been discussing, you've been trying to seek a consensus. If you're going to speak, would discussing the bill now assist that process, or do you think you should continue your discussions off camera, as we say? It's your call. We're trying to reach an agreement here. Would that be helped by your simply describing the areas of disagreement at this time?
Mr. Chairman, thank you. I think
I'm sorry. Go ahead.
Thank you. What you have before you represents 3 years of careful consideration and thoughtful negotiations, and the advocates are here today to kind of lay out what i's remain to be dotted and t's remain to be crossed. So with your indulgence, Mr. Chairman, if we could take a few minutes just to hear from
Sure.
all interested parties. Thank
I
you.
just wanted to be helpful to the process. I'm fine.
Yep. Thank
Okay.
you.
We'll go in, Wise, Elliott, Dudzik.
Thank you, Mr. Chairman. I'm here on behalf of a number of different physician groups. And I thank you for your patience and Delegate Kerr working with us. This has been a multi-year process. That being said, I can see the light at the end of the tunnel, and I do think those additional days will get us there, or at least get us to the point where we can come back to this subcommittee early next week and say, here are the 2 to 3 things that we simply don't agree on, and you have to decide. With your indulgence, Mr. Chairman, I think it might be useful to, because we've been involved with this so much, but I know the subcommittee hasn't necessarily, to give you, if I could, sort of the broad strokes of where the physicians come into this and what we've been trying to achieve.
Certainly.
Okay. So currently PAs operate under a supervisory relationship with doctors, and in a number of states, they have moved to collaboration, and we are supportive of that. There's still a collaboration agreement under this bill, but we've greatly simplified what is in it and the litany of requirements that are currently in the delegation, the supervisory agreement, if you will. We were very vocal about making sure there's proper guardrails so that whatever the physician assistant is doing, it's consistent with the practice of the physician, that it's addressed in the agreement, but we've agreed with them 100% that a lot of the processes involved here could be a lot more efficient, and also that more experienced PAs should be able to do more in tandem with the physician-led team. And I think the bill does most of that. I think it gets them a large portion of what they are trying to achieve, and in a way that the physicians support. We've got a couple issues that relate to the interpretation of studies and imaging by physician assistants, which is a sticking point. There are some settings where physician assistants are excused from board approval for what we call advanced duties. And we have some disagreements on what settings should get that excusal. But those to me are the 2 principal issues that remain. And Lindsay has worked very hard to put 2 drafts together, which I can tell from the time on it, she was working until late last night. And I've only read through about 25 of the 30 pages so far myself this morning. So I think we need to digest that and then come back together. But I do think that with those 2 issues on the table, and maybe I'm missing one more, but I think if we can get there on those, we'll do it in the next few days. And if we don't, we're going to just come back to you and say, you need to decide it.
Okay. Thank you, Mr. Wise. Robin Elliott.
Yeah, good morning. I'm here on behalf of the Maryland Academy of Physician Assistants and agree with my colleague, Steve. First, I want to thank Lindsay, who was up very late last night, produced a couple different versions of the amendment. And then I want to specifically thank Michael Tran of the Board of Physicians, who put together kind of the lion's share of amendments. We are close. I can see the light at the end of the tunnel. I agree with Steve. Just wanted to spend a couple of minutes describing all the work that the PAs have done in the last few months, so that just to provide some context about how much collaboration is in this bill. The first thing is, as you see, Lindsay has incorporated the Board of the Physician amendments. We do think those need some tweaking, but it was a late night, so we will come back to you on that. We also have reached an agreement with the Department of Health on how PA dispensing licenses will be handled in a way that is easy for them and streamlined for PAs and physicians as well. We have accepted some amendments from the anesthesiologist. Again, that was late last night. It got incorporated. I know the anesthesiologist and the CRNAs may need to take a look at that language. And we have worked with Steve, and I think we're very close on a number of, I would say, more wordsmithing concepts. The outstanding issues I would flag are that the Board of Physicians would like the PAs and are willing to make so on advanced duties, the board is willing to make exemptions in 3 areas. One is that if the PA has practiced 10,000 hours or more, so that's 5 years. Number 2, if the PA is practicing in a hospital or ambulatory surgery center. And then the third one is if the PA has been approved for an advanced duty before, just as long as that advanced duty is within the scope of the practice they are working in. The PAs would like some modifications to that. The first is that on the number of hours, we requested instead of 10,000 hours, it be 3,000. I think Delegate Kerr may be putting forward the concept of 7,000 hours as kind of a split the difference. We would also request being able for PAs to practice in also regulated settings, regulate in a different way, but federally qualified health centers, school-based health centers, local health departments, local detention centers and correctional facilities, because we think the quality assurances are there and it'll help us get PAs into primary care, which is what we desperately need. And then the third item is we have a difference of opinion with the Board of Physicians on PAs being able to delegate to medical assistants. And so I'm sure the board will speak to this, but we really think it's important that PAs be able to do that. If they can't do that, the practice settings in which they work can't function. We do have probably a couple other changes, but I want to, but they're more minor. So I want to pause because I know many of the other stakeholders would like to speak.
Thank you. Thank you, Robin. Matthew Dudzik, MDH.
Good morning, and thank you again to everyone, but especially to Lindsay for putting all this together into a readable document. It is so much easier to kind of go and review all of this when it's all in this reprinted form. So I really, really appreciate that. And also thank you to everyone else, especially Robin, who's sat down with us quite a bit to kind of, and been very responsive to a lot of the concerns that we still have, and of course to the PAs as well. We just to kind of elaborate on where those. I'm going to echo what Robin just said as far as the areas where the board and the PAs have some outlying or disagreements or outlying issues. Because I do think we're very close. So the way that this would be structured is, and so when we're talking about advanced duties, we're talking about duties that are typically learned on the job. So these are things that we generally say, you can't just perform, coming out of PA school, that doesn't prepare you, give you the clinical experience. None of this prevents a physician assistant from performing these advanced duties. I want to be clear first, because I think some people read this as you're only allowed to perform these advanced duties under these circumstances. You can still perform these advanced duties. You just have to demonstrate to the board that you have the training or experience. And generally the way that's handled now is a physician assistant will show that they have done this duty a certain number of times with a physician beforehand, because you can always perform these duties if you're performing them with a physician. This is more for performing them independently. So what we've looked at are ways we can kind of cut out when you have to do that proactive verification by the board. So that's, and primarily the board was looking at, the reason the board looked at like hospital type settings is because they have a required credentialing component, where even though it's not the board that's verifying their competency to perform these tasks, there is another body that's doing so, rather than it just being entirely determined at the practice level. There's an independent group that is looking at the qualifications of those practitioners. And so that's why we included the exemptions for hospitals and ambulatory surgical centers. Those are regulated by the Office of Healthcare Quality. They are, any practitioner there is going to be credentialed through the Joint Commission. And the board was comfortable saying that, it doesn't need to be us that's verifying it as long as there's some sort of independent group that's doing so. The other exemption would be if you've been approved in the past, right now, and this is just, kind of a silly way that the law is worded right now, because the approval is based on the individual delegation agreement. Right now, there's a situation where if a PA changes delegation agreements, their supervising physician changes, or they change employment or anything like that, they have to go through the approval process again. I don't think anybody, neither us nor the PAs, think that's necessary. If you've been approved, you've been approved, and we're fine with that. The final thing that the board agreed on after kind of exploring this issue more was, at what point are we comfortable saying that, PAs can kind of determine this at the practice level, and that's where the 10,000 hour recommendation came from. 5 years would encompass the majority of physician assistants in Maryland. We did a review. We don't track clinical hours currently because we don't have any reason to, but roughly 64% of physician assistants in Maryland have held an active license for more than 5 years. And that's not taking into account those who are practicing in other states prior to practicing in Maryland. So we do think this will encompass the majority of PAs. And it'll get rid of the scenario where somebody, who's only been out of school a couple of years and is taking on new employment might be pressured to, perform duties that they're not quite, that they don't necessarily have the hands-on clinical training. And so, the board, as I said, there still is some disagreement as to where that hour requirement is. The board does feel that 10,000 hours or 5 years is a reasonable compromise. We appreciate that this has moved a little bit, and we appreciate that the latest version shows 7,000. Regarding the additional settings, again, the reason that the board exempts is willing to exempt hospital and ASC physician assistants is because of that additional verification piece. So even though some of these settings are somewhat regulated settings, if there's no requirement that their credentials be verified, it doesn't really address those concerns. And to some degree, federally qualified health centers are of less of a concern because they actually do have some language where they can lose federal funding if they have an unqualified practitioner. So we're less concerned on the federally qualified health centers piece, but there's no such requirement for local health departments or school-based health centers in particular, nor is there.
Thank you very much. Thank you very much. Danielle Varanian.
Thank you so much. Danielle Varanian. I'm an attorney on behalf of the Maryland Radiological Society and RadNet, and with me is Haley Evans.
Good afternoon.
So the main sticking point right now for our clients is the portion of the bill that would allow PAs to perform and interpret diagnostic studies. We have not come to an agreement on that issue yet. We do understand that we don't want to go backwards, and we understand that in certain settings, particularly in hospitals, PAs are, doing an initial review of certain diagnostic studies. The concern that we have is that the bill's language doesn't distinguish with that. And there is no language in the bill that distinguishes that this is an initial review of a diagnostic study, but rather it allows the PAs to be the final review. So that is the point at which our clients are very concerned, because there's a significant delta in the education and training and experience between a physician's assistant and a physician. So that piece, the performing, excuse me, and interpreting the diagnostic studies is sort of where we're stuck.
But it is part of the discussions.
It is.
Yeah.
It is.
Fine. Okay, thank you.
Thank you.
Jennifer Witten, LifeBridge.
Thank you, Mr. Chairman and committee members. So I think a lot of my colleagues have kind of addressed from the hospital's perspective. We utilize and value PAs throughout our system. They're actually a critical component when we receive trauma patients and doing that quick analysis, and also in our critical care units. We also staff PAs throughout our urgent care centers, which you've heard us talk about on other pieces of legislation this session. So my main point here is just wanted to share a little bit is we do a pretty thorough process in identifying core privileges for PAs based on, again, their training and experience. And in those cases where we need them to specialize in certain areas, there is the opportunity to put forward an advanced procedure application to the board that includes a number of kind of specialized training. Again, that also includes some of the radiologic capacity that Danielle just shared. So what I'd like the committee to consider is what we don't want to see is that we start carving back existing capabilities that we have in place, as that would have significant hospital's ability to do that analysis and to ensure that we get patients assessed and treated in the most appropriate way. Just for some assurity in terms of imaging and some of the advanced procedures, PAs may do an initial assessment, an initial what we call a wet read or initial identification, but then always consult with the radiologist and the physician to determine the next course of treatment. So, and that happens in every setting that we utilize PAs in. So just wanted to make sure the committee had that information, and happy to answer any questions, but we just don't want to see existing practices be carved back during this process. So thank you all.
Delegate Hutchinson, thank you, Ms. Witt.
Thank you,
Delegate
Mr. Chair.
Hutchinson.
Thank you, Mr. Chair. Not sure who's the right one to answer this. Maybe it's Danielle, but how does this bill as it stands now in terms of reading images compare to other bills that we put forth, you know, for nurse practitioners or others? And is it any different or is it the same?
That's a great question, Delegate Hutchinson. The language that we have proposed to the PAs is, excuse me, actually the language that was adopted by the NPs last year. So what that would mean for this bill would be on page 13 of the bill, we would take out paragraph 4 that says ordering, performing, and interpreting diagnostic studies, therapeutic procedures, and laboratory tests, and replace that with just the paragraph that's underneath it, the ordering diagnostic tests and using their findings or results in the care of patients. That paragraph 5 is the same language that is in the NP statute now. And I'm not saying that we would take all of that language out, but that performing and interpreting diagnostic studies piece would match the NPs.
But if it was the same as the NP language, you would be favorable? I mean,
Yes.
you would be favorable of that.
Yes.
And so for the other side, what's the issue of not having the language match the NPs?
Robin Elliott, are you ready to answer that question, or should I go to Jennifer Witten, who just raised her hand?
I have, I think, part of it, and Jen may have another piece. So thank you for the question, Delegate Hutchinson. NP practice and PA practice is structured very differently. As you know, NPs have full practice authorities. Sometimes people call them independent practitioners. The way the bill is structured, in any scenario of the amendments, there are a lot of guardrails in place so that the PA is only providing services for which, one, the physician or physicians in the agreement have agreed to. So it's physician-led, or physician-driven, that what the PA is doing has to be within their education, training, and experience. And the last piece is that it has to be within the practice of the physicians involved in the collaborative agreement. So PAs actually work in very different places than NPs and even clinical nurse specialists. So we don't think it's appropriate to have the same framework. And we'll just point out also that the word diagnostic isn't defined anywhere. It could really catch a broad number of types of studies. And depending on how the Board of Physicians ends up interpreting the proposed amendment, it could really pare back what PAs are permitted to do. And so that's why we are opposing that amendment.
Jen Whitten.
Yeah, thank you, Mr. Chairman, and thank you, Delegate Hutchinson, for the question. So I'll just talk about it in practicality. So at least in the hospital setting, PAs are typically the first line of the providers when a patient comes to the ED and needs quick assessment, especially for our trauma patients where we're trying to activate our trauma team. So having that early assessment done by the PA and sometimes doing those quick imaging to identify, what major issues we're dealing with before the trauma team gets there. All of those things then are confirmed by the trauma team, including the physicians and the radiologists, but we typically have PAs doing that initial piece for us. So that would have a significant impact if they're not able to do that first line of assessment to get folks assessed quickly in that kind of time sensitive period. We don't typically have NPs doing that. And again, we spend a lot of time developing those core privileges and working with the Board of Physician on those advanced practices that kind of define those scope of duty. So that would be pretty detrimental, at least for the ED practicality and some of the other settings in the hospitals.
Thanks for everybody for explaining all that for me. Thanks.
Last person, Mr. Wise.
Thank you. And just to respond to that, the hospital is treated differently under the bill when it comes to advanced duties. They basically don't have to seek board approval for what the PAs do there because they have such a strong internal regulatory structure. This language that Danielle pointed out is also applicable in independent private practices where you don't have those safeguards. And that's why we're trying to make sure that language is appropriate there. And the reason we furnished the nurse practitioner language from last year is because much of the rest of that same section mimics what is in the nurse practitioner statute. So that's where it came from and the reason we chose it.
Thank you. All right. Well, we want you guys not to go back to your corners, but to continue negotiating. And I will say for everyone that the committee, when we adjourn today, we will reassemble before next Wednesday. We don't know when, but for this bill and for 806 as well as other bills still before the subcommittee or before the committee, next week being crossover week, we are likely to come back more than once and almost certainly before Wednesday. There being no other business before the subcommittee, we stand adjourned. Thank you.